So thank you very much for this introduction, and I would like to thank you all for this organization, and to thank SSBMT and EBMT to give me the opportunity to talk about this exciting topic that is CAR T cell in ALL. So these are my disclosures. And we are aware that in children, most of the patients luckily will be cured with after treatment for ALL. However, there is always 10% of the patient will relapse. And in adults, around 40 or 50% of patients will relapse after the first line. And regardless of age, patients with relapse or refractory ALL have a dismal prognosis. Traditionally, patients with the status of treatment have required allogeneic stem cell transplantation for cure, but however, most patients do not proceed to transplant. And you're all aware that CAR T cell therapy has transformed the treatment of hematological malignancy for both ALL pediatric and adult patients. As you can see on this schema, that many drugs have been approved the last 5 years, like blinatumomab, inotuzumab, but for CAR T cells, we have tisagenlecel and brexucab. And I would like to talk about the last study that had been published 1 year ago in adults. It was a phase 2 study, the ZUMA-3 study, that include only adult patients were relapsed or refractory ALL, and the median time to leukapheresis to receive KTX-19 was around 13 or 40 days. The median follow-up of the study was 16 months, and you can see that 671 patients were enrolled, but 55 were treated, in fact, and the patients were heavily pretreated when you look at the number of previous therapies. What about the efficacy? So in all, more than 70% of the patients had an overall complete remission or a complete remission with incomplete hematological recovery. And when you look at the median duration of remission, patients with CR had a median duration of remission of almost 50 months. When you look at overall survival, for all the treated patients, the median overall survival was 18 months. But when we did a focus on patients in CR or CRI, the median follow-up was not reached. And for patients who did not achieve CR, the median follow-up was only 2.4 months. It was really interesting data, especially when you know that patients can achieve CR. What about toxicity? So most of the patients, 75% of the patients had a severe adverse event. It is important to note that 3/4 of the patients had a grade 3 cytopenia that were present more than 1 month, and this is what we see in clinical practice. Almost 90% of the patients developed CRS, and 24% more than a grade 3 CRS. In clinical practice, and this is what we see, the median time to onset CRS is 5 days, and it lasts around 1 week. For neurological events, this is a little bit more rare, it's 60%, but 1/4 develop a grade 3 or grade 4. And the median time to onset ICANS is a little bit longer than CRS, it's 9 days, and the median duration is also around 1 week. What about infection? 25% develop more than a grade 3 or grade 4 infection. So when they look at the biology, you can see that the median time to peak CAR T cells on blood was 15 days, and there was an inverse relationship between CAR T cell expansion and bone marrow blast. And at 12 months, in the 10 to 12 ongoing responder with evaluable sample, all had recovered B cells, and only one had a detectable CAR T cells. So the study was really important because thanks to this study, the product was approved, but it showed that a single infusion of KTEX-19 could induce durable remission with manageable safety in heavily pretreated adults with relapsed or refractory BLL. When you look at the different studies, both pediatric and adult clinical trials of CD19 targeted CAR T cell therapy have shown MRD negative complete remission. And this is a really impressive result. However, when you look at Eliana's study with a median follow-up of 2 years, the relapse-free survival was 62% with a plateauing of the probability curves after 1 year. But in adults, the median duration of response is between 8 or 19 months, with important variations in the proportion of patients receiving consolidative transplant in CR treatment. And this is really important to determine, to look at the risk factors associated with the response after CD19 CAR T cell therapy. When we put different studies, the most important characteristic and prognostic factors are tumor burden, tumor kinetics also, and the CAR T cells persistence and function. Another important question in clinical practice is what is the impact of blinatumomab used before CD19 CAR T cells? And Myers and colleagues did a retrospective multicenter study in children and young adults who received CD19 CAR T cells. And the primary objective was to evaluate relapse-free survival and event-free survival rates 6 months after CD19 CAR infusion, stratified by blina exposures. And you can see on this table that 77 patients received blina before CAR T cells, and 343 were blina naive. In fact, the characteristic of the patient was not exactly the same. Blina naive received CAR T cells after the median time for prior transplant to CAR T cell were longer in blina naive, and also more patients received transplantation blina exposed. So when they look at the complete remission rate following CD19 CAR T cells, they can conclude that they were comparable between blinatumomab naive patients and blina exposed patients who responded to blina. But it was worse in blina exposed non-responders. So I think it's really important data. If your patient responds to blina, you don't expect to have a lower CR rate. And cumulative incidence was higher among blina exposed non-responders than either blina exposed responders or blina naive, with 6 months cumulative incidence of relapse of 52% and 26%. They also show that a high disease burden was associated with worse survival, so it was confirmatory. One question was, we know that blina may lead to CD19 downregulation. So they look at the expression of CD19 when patient relapse. And for patients in whom CD19 expression diminished or changed following blina, the risk of post-CAR relapse with CD19 disease was high. And blina patients with CD19 dim disease pre-CD19 CAR had the worst outcome. However, they don't have enough power to really see if the CD19 downregulation has a significant impact on the response. but there is really an interest of monitoring CD19 expression for our patients. What about patients who receive transplant? Almost 100 patients proceed to transplant in the first year after CAR T-cell. It was for 57% planned CAR as a bridge to transplant, and 43% received transplant because of loss of CAR T-cells or loss of B-cell aplasia. And you can see that the survival of this patient, the outcomes of the patient were really good when we consider the high-risk patient. The 2-year overall survival was 78%, and the 2-year event-free survival 71%. So what about transplantation after CAR T-cell therapy? Do we need to transplant patients after CAR T-cell therapy? This is a really difficult question and answer. So Sharon colleagues have recently published the long-term follow-up of CD19 CAR T-cell therapy in children and young adults with B-ALL. There were 50 patients were included in this study with a median age of 13 years old. 62 achieved CR, and 75% patients achieving MRD negative proceeded to transplant. The median follow-up was 4.8 years, and the median overall survival for the entire cohort was 10 months. And the median event-free survival was 3 months. When they look at the median overall survival from transplant day 0, it was 70 months, and the 5 years event-free survival following transplantation was 62%. 2 patients relapsed after transplant, and so it was interesting data, but of course, patients who proceed to transplant usually had MRD negativity. All 7 patients who achieved an MRD negative CR and did not proceed to consolidated transplant experienced relapse at a median time of 152 days post-CAR T-cell infusion. And importantly, the decision to undergo transplant and the choice of preparative regimen were not detected by the protocol. So this is really a retrospective data. So CAR T-cell followed by a consolidated transplant can provide long-term durable disease control in young adults and children with relapsed and refractory B-ALL. So we talked about autologous CAR T-cells, but what about donor-derived CD19 CAR T-cell therapy of relapse of CD19 positive B-ALL post-transplant? So Zhang and colleagues report 43 patients with B-ALL who relapsed after allogeneic stem cell transplantation with no prior active GVHD and who refused to receive a second transplant. The median age of this patient was 24 years, and 17 patients received a matched sibling donor and 26 a haplo donor. So they received, in fact, 2 different types of CAR T-cells. What about the safety? So CRS of any grade was developed in 38 subjects, and 7 patients developed grade 3 or grade 4 CRS. 9 developed ICANS, and 2 patients developed active GVHD, but it was a grade 1 or grade 2 GVHD. So the safety was quite expected and good about GVHD. 41 subjects survived more than 3 weeks and were evaluable for the response, and around 80% achieved CR. The 1-year probability of EFS and OS was 43%. So this is quite interesting because this patient already had been transplanted and received CAR T-cell after transplant, so have very high risk of relapse and and you have like more than 43% who are still alive at 1 year. When they look at the CAR T-cell dynamic, the peak was at the day 9, and the median interval of detectable blood CAR T-cells post-infusion was 90 days. The also interesting question is how to do to have in fact a very product that is very rapid, very quick to produce. And Roddy and colleagues show a durable response and low toxicity after fast off-rate CD19 CAR T-cell therapy in adult patients. The name is AUTO1, it's a novel CD19 CAR T-cells. This is a CD19 targeting single-chain variable fragment that has a lower affinity for CD19 than FMC63 that is usually used in the licensed CD19 CAR T-cell product. And this is a fast off-rate which imparts rapid dissociation from CD19. And the hypothesis was that it could induce less CRS, less toxicity, and less T-cell exhaustion that may enhance CAR T-cell persistence. So it is a phase 1 study, and you can see that patients received CAR T-cells, 2 days of CAR T-cells, in fact, and the first assessment was at 4 weeks. 26 patients was registered and 20 received this CAR T-cell with a median age of 41 years old. What about toxicity? In fact, only 3 patients experienced a grade 1, 8 a grade 2, and there was no grade 3 and no grade 4. So it seems to be less toxic, but this is really a phase 1 study. About ICANS, 1 patient developed a grade 1 and 3 developed a grade 3, and 3 that were all resolved by steroids. There were also cytopenia, and no patient developed a new GVHD. The CAR persistence were detected in most of the patients around 6 months. And the response rate and survival, in fact, was really good because 17 achieved MRD negativity at 1 month. And the event-free survival at 1 year was 48%. Last thing I think is really interesting in our clinical practice is T-cell cell outcomes in relapsed and refractory extramedullary ALL. And in this study, 55 pediatric patients with extramedullary disease received CAR T-cells. So patients could have a CNS disease or a CNS and a combined bone marrow disease, or only extramedullary disease. 88% of the patients with CNS disease obtained a CR, and no patient with active CNS disease at infusion experienced grade 3 or grade 4 neurotoxicity. At 1 year, relapse-free survival of a patient was only CNS obtained 60%, 66%, but the 1 year RFS of patients who had CNS and the bone marrow involvement was 49%. And patients who had only extramedullary disease, the response rate was 66%. And usually these patients were excluded from clinical trials. So it was important to see if CAR T cells can attack extramedullary disease. So CD19 CAR T cells for relapsed and refractory extramedullary disease offer an effective option with similar toxicity and overall survival rate compared with patients with bone marrow only disease. Another quick, it's about, because we talk only about CD19 targeted CAR T cells, we have many publications on CD22 targeted CAR T cells. And I would like to talk about this very recent publication about Spiegel and colleagues, whose CAR T cell with dual targeting of CD19 and CD22 in adults. It was a phase 1 study, and they include patients with ALL, but also with lymphoma. In ALL patients, the median age was 47 years, and they were heavily pretreated, and you have to know that 65% had previous CD19 directed therapy and also CD19 22 therapy. All patients with B-ALL achieved a response, and 14 with a CR and 3 with a PR. So it's really an impressive result. 5 of 10 patients with B-ALL with progression had negative or low CD19 expression, but with preserved CD22 expression. So the resistance to the B-specific CAR was associated with CD19 plus CD20 plus relapse, probably reflecting intrinsic limitation of CAR T cells, as well as CD19 low, but CD22 plus relapse, implying inadequate immune pressure on the CD22 target. So it has to be more developed by CD22 targets. And this is other studies that can look with very interesting results about dual CAR T cells. So to conclude, CAR T cell therapy is transforming the treatment of relapsed and refractory ALL, but significant challenge remains. Also, CD19 CAR T cell therapy achieved high rates of MRD negative response in 80% of the patients. Relapse are common, mainly in the first year, and the duration of response remains limited in adults. Current strategies to improve CAR T cell efficacy focus on improved CAR T cells, in vivo, multi-specific CAR T cells to overcome immune escape and new CAR designs. And access to CAR T cell therapy remains a major challenge, considering the manufacturing process and also the cost. So I would like to thank all the Saint-Antoine team, and I would like to thank you for your attention, and I will be happy to take any questions. Thanks.